Hello, good afternoon, and would like to thank Dr. Dogra and the team for giving me this opportunity. And the purpose of any vitrectomy surgery is to achieve the goals. And be it reattaching the retina, removing the vitreous opacity, relieving the traction, or removing the fibrovascular tissue. But it should be done in such a way that you just do enough and no more. You don't want any complications, basically. So what I would like in this short talk of 10 minutes to go through highlight some of the important points which are basic points which I put into practice and that enhances the results. And then later on, I think more complex aspect will be taken up by other speakers. The first point I would like to highlight is through this video. This is a case of a proliferative diabetic retinopathy premacular hemorrhage. I think the leitmotif of this talk is going to be removal of this posterior hyaloid phase. In all cases, you need to remove the hyaloid phase as much as possible. And once you remove the hyaloid phase, you have the vitreous hemorrhage. In this video, my main point I would like to show you would be at the end. So basically remove it. And now I think people should spend at least 20 to 30 seconds in all surgery. Just do a little bit of hypotony and see if there is any bleeder is there or not. I think it's very vital. If you don't do this thing, then next day, neither doctor will see inside anything, nor the patient will see outside. So it's better to spend 30 minutes, switch off the infusion, do the hypotony, and identify the bleeder like that. Again, reconfirm it whether it's stopped or not, or you do the laser again. I think it's very vital, simple point to do it. So next day, if you do that, then the eye is like that. So first point, a simple point, please identify all the bleeding points at the end and treat it. And that's why I got little bit of reservation regarding this sutureless sclerotomy, because I like the pressure to be little on the higher side. And I found that I don't get that pressure when I use this self-sealing sclerotomies. Most of the people who are sitting here must have done, they must be doing vitrectomy. And there are certain situations that are quite frustrating, that you are doing a nice surgery and you come across a patch of fibrovascular tissue and it bleeds. And you spend sometimes more time tackling that bleed than the actual surgery. So let me show you a few films what I do now. I think videos are not, okay. So basically, after you remove this, most of the opacities and this thing, as you see here, I'm trying to remove the last piece and the bleeding starts. It's a very common situation. And sometimes whatever you do, you cannot do anything. So nowadays, I just leave it like that. I don't remove the whole tissue. I see there is no active bleeding, and then just do the laser. Mostly tamponade is not required. And the results usually are nicely regressed fibrovascular tissue. Again, the same point I want to emphasize, another case. And some point you come, it bleeds. So what do I do? That I first see that besides the epicenter, I cut off all the attachments. So basically a flat fibrovascular tissue, I'm trying to make it into a form of a flower. So all the tractions are relieved and all the bleeding points are taken care of. Some people might just do the cutter and chop it off, but it bleeds a lot. You don't want to take that risk. So in this case, since it was a large piece, I put a silicone oil in the eye, and after 2 months, I removed the oil. So this is when I'm removing the oil. You see nicely that is almost dissolved, nicely regressed new vessel. And this is the fundus picture of the same showing the thing. And just one more video will show the same point which I want to raise. Here again, most of the things are removed nicely, and you're removing this fibrovascular tissue, and you come across one patch which you cannot do it. So again, I do the same, and you will see the nicely regress. Again, please don't get a wrong impression. In most of the cases, we are able to remove all the fibrovascular tissues. But in some situation, the bleeding happens and you are stuck. And before that, I have try to remove that, and it bleeds again. Remove the clot, again it bleeds. So it's safe to leave behind as long as you relieved all the traction. Now let me show you. Okay. Now this is very important. Way back in 1970, when Bob Markheimer came out with his first monogram on diabetic vitrectomy, he said that the posterior cortical vitreous is most important, and it acts as a scaffold for causing a fibrovascular tissue to grow on this. And he emphasized, I think it's very pertinent today. The reason I tell, because a lot of videos are being shown that they use the cutter. I will show you what I do to remove the posterior cortical vitreous. And cortical vitreous has to be removed. So to remove the cortical vitreous completely, I would prefer an unblocked technique which removes it full, and you have to identify vitroschisis, which is as high as around 30 to 40% in a diabetic vitrectomy. So to do that, I'll show you with an example. This was a case. This was a case of tractional maculopathy. Along with that, the patient had a proliferative diabetic retinopathy and totally attached cortical vitreous. So basically, what I do is wherever I try and find a plane in between the cortical vitreous and the retina, I enter the scissors. I basically use two instruments, scissors and the bent needle, and you identify all the epicenters. It's very vital, and you cut those epicenters. Sometimes you can strip it, but you will see very soon that I was over enthusiastic. I try to strip, and what happens? So once you have enough of the hyaloid, this thing you cut off. Otherwise, you'll transmit all the pressure from here, all the traction from here to the periphery, and you can get a dialysis in the periphery. So once you do that, you remove the rest of the cortical vitreous. And as I was saying, that if you just overexcited, you can make a retinal tear. Luckily, there was no bleeding, and nicely all the cortex is removed. And the last, because of the traction on the macula, is preferable to remove the ILM as well. And after doing that, just do the laser, and air is okay in this patient. So the patient mostly recovers good, and the macula goes back. Just to emphasize that point again, the same situation, you get a cortical vitreous nicely attached, and as I said, if you don't remove the cortical vitreous, it's like doing a cataract surgery, and you don't remove the posterior subcapsular opacity. You have to remove the cortical vitreous, whether you are doing a case of a diabetes or you're doing a non-diabetic case. Cortical vitreous needs to be removed. And again, the concept is same. Once you are identify all the epicenters, and sometimes the blood is there. Actually, I don't remove it first. It helps you to find the plane between the retina and the cortical vitreous, and you remove strip again. If you do unblock, you are sure that you are not leaving any vitreous behind, identifying the vitroschisis, and the whole vitreous is nicely removed. This is just to highlight the point of a vitroschisis. You see, there are two layers of vitreous. Here it is easy to identify because both the layers are opaque. Sometimes a very, very clean layer, clear vitreous remains, and that you have to identify and remove both the layers of the vitreous. So unblock technique is important. I'm coming to the end, so maybe I will. This is just a very quickly, I'll make a point about this peripheral traction with retinal detachment. I find are very difficult. I normally don't go to remove all the fibrovascular tissues in the periphery. I'll make vertical relaxing incisions. Sometimes it's required just to support it from outside with a buckle, and very, very rarely I do the relaxing retinotomy. But most of the time it does work. You just relax as much as possible. Don't go and try to remove all the things in the periphery. So this is the same patient. So basically what I would end with three simple things. First thing is that spend 20-30 minutes, identify all bleeders. I think it's very important. Lot of times when you do, I remember when earlier when people vitrectomy, they used to do the incidence of post-op bleed was as high as 70%. You have to identify the bleeders and keep the pressure a little bit higher. That's number one. The knowledge says you remove all the fibrovascular tissues. The aim is also the same. We remove it, but sometimes be wise. You can leave behind a part of it. It doesn't cause any damage unless two things are there. There is no active bleeding and all the traction from there is relieved. And last, I think the sine qua non of all vitreous surgery is to remove most of the cortical vitreous, and I feel the unblock technique does the best. Thank you.